where did I start with this? When I first obtained the chair in treatment and care, I was very interested in mental health and ASD. And the focus, though, was most definitely on mental health problems. And the idea is, and why, there's considerable data, not just from research that we're doing here in Canada, but from excellent data from the UK, to indicate that youth with developmental disabilities, broadly speaking, struggle more often with emotional and behavioral problems than peers living in the same areas, in the same contexts, same environments. Well, not exactly the same environments, that's a bit of a misnomer. In the same communities, I should say. Large-scale studies, survey-based, census-based studies in the UK of over 18,000 individuals, not all with ASD or with intellectual disability, but 18,000 in general. What Totsika and others have done, for example, is they've zoomed in and said, okay, what are the rates of clinically significant emotional and behavioral problems, according to Parent Report, at least, in typically developing youth, 5 to 16 years of age, in youth with ASD, diagnosed ASD, youth with an intellectual disability without ASD, and youth who have both an intellectual disability and ASD. And that's the graphs I'm sharing with you right now. And what I'll show you is that, okay, so what do rates look like? Well, in a typically developing youth, if you ask a parent, to fill out these questionnaires, about 1 in 5 parents would rate their children as having significant emotional and behavioral problems. So 20%. That's still very high and something that we have to be concerned about. When it comes to youth with an intellectual disability who don't have ASD, rates are about 40%. Which is, again, significantly greater than we would expect. And then if you looked at the two other bars, which are ASD and people with intellectual disability and ASD, rates are at about 60 to 70% at any one moment in time. These are clinically significant or important emotional and behavioral concerns that parents are reporting. So this is the majority. If we were to do psychiatric interviews to take into account autism symptomatology so as not to double count difficulties, and we started to ask questions about major depression or about specific types of anxiety disorders or about attentional difficulties or oppositionality, if we were to look at a checklist, we would see very high rates as well of overlap among individuals. When Leifer did their much smaller study, admittedly, in the US of 109 youth with ASD, they found that about 70% of the youth met criteria for at least one associated psychiatric condition. And that's at least one. There's considerable overlap as well. But what I liked about their study is that they didn't just look at who met the 6 out of the 12 criteria that are required for a psychiatric disorder diagnosis of X or Y. Right? What they did is they said who was having difficulty, even subclinical levels of that same issue. For example, when we thought about depression, although 1 in 10 of these youth would meet criteria for a major depressive disorder in the moment, there's another 14% in addition to that have subclinical levels that are still struggling tremendously with sadness and the associated difficulties related to depression. So about 25%, we're really talking about a quarter, are dealing with these issues. And I think that's more the reality. It's less important to say how many people meet, this number of criteria, for example, as it is to say, as a whole person, how are you struggling with sadness? Are you struggling with anxiety? Are you struggling with anger or behavioral issues, regardless of whether there's a cutoff or not, because it's impacting your learning, it's impacting your living. The point here is that all of these things are very important, right? And I don't think anybody here would say they're not really important. And we'll get to why am I spending all this time talking about it when you came here to hear me talk about thriving. But there's a reason. Just stick with me for a second. So back to BC now. Okay, so here's some BC-specific data. We asked in that CASDA survey, caregivers and self-advocates, do you currently have any concerns about problems with, and we said, anxiety, or with your child, does your child currently have problems with anxiety, depression, anger, hurting others? So it's not a psychiatric interview, far from it. So what you see here are rates that said, yes, this is currently a concern for us. In terms of caregivers of preschoolers, you could see that the most common concern was one of anxiety at over 45%. Depression really wasn't a concern yet. Anger was still high. Their children hurting others at 30%, or self-injury and destroying property. These were some concerns that caregivers of preschoolers were noting. When we look at caregivers of school age, youth in BC. We see an increased rate around concerns around anxiety. Now this is parent reported concerns of their kids. We see now an increase in concerns about their child's depression, about feelings of depression. Anger is higher rates of anger. And then a similar rate around concerns around hurting others, around self-injury or destructions of property, and a small indication of a couple of people where there are problems with the law as well. Okay? So these are, again, there's lots of overlap here, but to say that these concerns are very relevant and we need programs in BC like we do in other parts of the country that help support problems when they arise like this. Right? What about adults? So this is caregivers reporting on adult age children, usually, and we see that very similar profile as to the school age youth, with an increase again in depression, concerns around depression, in a slight increase or higher levels around problems with the law. But again, the numbers are also much smaller here for adults, so things can be a bit inflated. But the point here is that we see kind of a similar pattern with some increasing over time. And then when those 21 self-advocates, when they reported about concerns about themselves, these were their concerns. Right? So very high rates of concerns around anxiety, around depression, very high for that very small sample that provided information. And then we see not as much problems around anger or hurting others or self-injury. But certainly, so what do we take away from this? Well, we take away that both internalizing difficulties as well as externalizing difficulties are very important to take into account when we're talking about care. If we added up the number of those out of 7, the number of concerns, you can see that in terms of preschoolers, there's about 30% that said, I don't have any concerns, which is good around those 7 issues. I have other issues or priority needs, but it's not of those behavioral or emotional difficulties. And then we see kind of rates around 1 of those concerns, 2, or maybe 3 or more, are all at about 10 to 30%, right? So that's important to note, is that about 30% had 3 or more of those behavioral issues that I just showed you as concerns, okay? Caregivers of school-age youth, you can see here that actually the highest, the mode, is 3 or more concerns. At about almost 40% of those families checked off, of those 7, at least 3, if not more. And with the adults, we can see it's a little bit, again, distributed, and in terms of self-advocates, where it goes. The point here, again, is that we're not just talking about one problem. When we start thinking about problems, it's actually, when we see one thing, we're actually seeing probably many things, right? There's a lot of overlap and correlation among different kind of issues. So why are these rates so high, conceptually? Jeffrey Wood and Godot published a theoretical paper to try to understand, why are these rates so high that I just depressed you with, of emotional problems, of behavioral issues, what is going on here? And I really like their conceptualization. What they suggest is that youth or people with ASD are living in a world with a tremendous amount of ASD-related stressors, okay? That's the first kind of column. Okay? What they do is they were talking about youth, but I think it extends very well to adults as well. So these are the day-to-day kind of stressors. These are not the acute traumatic events that one can experience. Okay, those acute negative, these are the things that we're living with moment to moment, multiple times a day. It's part of our life. And people with ASD, they suggest, are living with more of these kind of stressors. And they group them into 4 kind of families, so to speak. The first one is walking around every day with an experience of confusion around your social context, about feeling that your social interactions could be unpredictable, about an anxiety that's related to being in novel social situations or those social demands. And again, this is not a blanket. Everybody's going to experience these things differently, but I think we can all relate to that and understand where that might be coming from. A second component or family is an experience of peer rejection and victimization that's related sometimes to ASD symptomatology. It doesn't mean that people, now this is important, and I go off on a lot of tangents, it doesn't mean if somebody's experiencing bullying and the content of that bullying is because they love to talk about fish all the time, so people are picking on them because they love to talk about fish. The answer is not to get them to stop talking about fish. But the point that Wood and Godot are saying is that it becomes an easy target for peer victimization, and that person experiences it as being related to who they are and what's important to them, or part of who they are. So it's It's a huge stressor that can happen. A third family is what they describe as prevention of or punishment of preferred repetitive behaviors or interests. So what they're talking about here is, if I love to, focus on, talking about, I have a client that I work with who loves roads and maps, and all of our sessions whenever we meet together are really talking about, we start by talking about that. He asks me, how did I get from my house to, the university and we really map out the roads, the routes, how much time it takes. It's really important to him to know, and it's really fun for us that's how we get along to start with. But if I were to withhold that information, if I were to say to him, don't talk about that, we have to, focus on your math right now, or it's not time for that right now. Although that's life sometimes, and it happens, in terms of a stress, that's an aversive experience for him, even a minor one, a small little thing, right? It's not going to send him off. He understands, okay, I have to compartmentalize this, and I have to shift to talking about what Jonathan wants to talk about, but there's still a stressor related to that. Okay? So that's a very minor, and obviously we can have a much more overt stressor related to this, where one actually is punished or for engaging in a behavior that they're expected from other people not to engage in. Right? A whole set of ASD-related stressors related to that. And lastly, this idea of aversive sensory experiences that we know are part of ASD experience, and that's a daily thing. So the point of all this is that people are going around with these ASD-related stressors, and the more you experience them, the more social anxiety you might feel, or the more negative affectivity and emotionality you might feel. And because of that, there are consequences of that, where there's increased social avoidance or increased ASD symptomatology. And then when you have those increased ASD symptoms, you get more ASD-related stressors. Right? And then you get more negative affectivity, and we have this negative cycle. Does that make sense? So I'm not going to go into any more of this, other than to say that this is a big issue. Now, why did I spend the first 10 minutes of this talk on thriving focusing on that, right? This is an experiment. There's actually kind of an experiment with everybody, okay? It's because if we focus on measuring those very important problems, right, then what we do is we start to, and I hope people are thinking, well, what should we do about that? Right? What kind of, maybe some people are actually thinking about, what kind of programs do we have here in BC that can help with anxiety or help with bullying or help, and those are very important ideas that if you were going there, good for you, that's important. My experience has been, though, if we focus solely on that, then it's that expression of, if all you have is a hammer, then everything's a nail. Right? If all we see when we're thinking about, okay, how do we promote mental health in a person is questions about problems, then all we have as solutions are programs that address those problems. Okay? So it's a very important part of the whole picture, but what I want to now ask us to do is move you beyond that. So what we just experienced, so as an example of that, as an example of what I mean by the nails, okay, so that was all about the hammer, was the problems. In terms of the nails, there's a lot of evidence now, a lot of research has gone in over the last decade to show that cognitive behavior therapy is effective for a substantial subgroup of youth with ASD who don't have an intellectual disability, specifically around anxiety, because of how much talk and focus and measurement there has been specifically on anxiety. It makes sense that this would be a consequence. Most of the studies that exist, and lots of actually randomized controlled trials, most of them that exist have been for youth 8 to 15 years of age, similar to those measurements that I showed you before in terms of the studies. Usually the CBT involves 14 to 16 sessions, so it's time limited, which is very nice, but they go up to 30 or so sessions. About half to 70% of the youth who participate in those CBT interventions demonstrate some considerable short-term improvement in anxiety. That's pretty good. It still means that there's about 30% to 50% of youth who participate who don't show improvement, and we have to understand why. That's the case. And we don't know much about long-term outcomes. There's some evidence to say that for those youth who make considerable gains, that they lose some of those gains within a year, but we don't really know much more than that around, we need more research on that. But the point is that overall, there is an evidence base around anxiety. Lots of lab-developed research. There was one study that tried to help youth with ASD around anger. Okay, not around aggression, but it was around controlling their anger. And 2 small pilot studies, including one that we're doing at York. We have a randomized controlled trial now ongoing around promoting emotion regulation more broadly in ASD. And maybe ACT will have me come out next year to present specifically on that. But the point is that we've all, including myself, have fed into the really important research on how do we develop evidence-based treatments for these kinds of problems. And that kind of research eventually translates, right? It takes about a 10-year window from that lab research to kind of hit the front lines. But when it's done well, it translates into resources that we can purchase and use in our communities. Anybody here do Facing Your Fears? Raise your hand. So Facing Your Fears, Judy Raven's work, right, came out of this story, this narrative that I'm talking about, right? Has anybody purchased the Exploring Feelings books by Tony Attwood, the red and green? Okay, so and what's the difference between the red and the green one?
The red one is anger and the green one is anxiety.
So the difference is the word anger and anxiety and the color of the book. Isn't that interesting? That it's the same kind of activities for both of those, right? So just we'll put that aside for a little bit, It's not content specific. But so people have purchased that came out of that research. Jeffrey Wood's one is less purchased, but it's an individualized family-based CBT for youth. So we have both individualized versions, we have group ones, we have ones that have been developed specifically with ASD in mind, like Judy Raven's, or ones that have been around for 30 years, like Phil Kendall's Coping Cat, that has been adapted and shown to be equally as effective. So you can have ASD-specific ones or ones that are general, that are adapted to the unique learning needs of individuals. This is all really important. So we see now a narrative of measuring problems well, understanding the relevance of that and the dynamics under that, having a good conceptualization of it, moving to lab-based research, and moving to resources that we can implement in the community. Okay? Now this is an optimistic view of developing evidence-based treatment research. And there are lots of what we call valleys of death in here, where there's good research that fails to translate and there are issues around that. But so to speak, overall, this is an important pathway. Okay? Around ASD, people who have ASD and intellectual disability, who have both of those, there's a similar pathway around behavior therapy, so moving beyond CBT, as well as mindfulness-based approaches that have shown some, long-term effects around aggression and anxiety. I always like to say here, and I'll present Souls of the Feet in a little bit, but these have very long-term outcomes. Some of these single-subject designs last for about 3 years in terms of the follow-up period, which is very interesting. However, it does require daily intervention, daily practice. So it's not something that people come in once a week to do, right? It's challenging to deliver and implement, but when it's done well, it can have very successful long-term outcomes. Fantastic. But what I want to suggest is that the absence of mental health problems and a reduction of mental health symptoms is not the same thing as good mental health.